is Bianca Gonzalez, and I'm very excited to introduce our 4-part autism webinar series in honor of one of our foundation's founding doctors, Dr. Herman H. Stone. This is the Riverside Medical Clinic Charitable Foundation's 5th annual memorial event, and we would like to thank our premier sponsor and individual donors, the Riverside Medical Clinic, Dr. and Mrs. Joseph Sohn, and Dr. and Mrs. Nate Olson. We truly appreciate your support. Just so everybody knows, we're going to have a short Q&A session at the end of this presentation. So please feel free to leave any questions or comments, and I will go ahead and hand them off to our presenter towards the end of the presentation. So all of your questions and comments will be answered and discussed at the end. So I would like to go ahead and introduce our speaker for today, Dr. Ira Heilveil. He is a licensed clinical psychologist, doctoral level board certified behavioral analyst. He is assistant clinical professor of psychiatry at Geffen UCLA Medical School, the author of 2 books, multiple scholarly articles and presentations, and holds a private pilot license. He is currently the president and co-founder of Hyperion Behavioral Health Center. And without further ado, I will go ahead and give it away to Dr. Heilveil.
Thank you, Bianca. It's so strange to be doing this without being able to see my audience. So I won't, and I can't hear you either, so I don't know. I should probably stay away from jokes because I won't know what kind of jokes we'll go over or not. Anyway, it's nice to be here. And I will go ahead, and I have this PowerPoint that I prepared. And so let's just kind of go forward. I'm here to talk about autism and a little bit about treatment methods and primarily about applied behavior analysis. So first off, what is this thing we're talking about when we talk about autism? It comes up every day in my professional world, and sometimes when I tell people what I do for a living, it comes up at other times as well. Hard not to talk about autism these days. It's all over the place in terms of the news and the Good Doctor on TV and so many other places. So essentially what we're talking about is a group of very complicated conditions. And I'll use words like conditions and disorders simply because I'm going to distinguish autism from diseases. And I think that's an important point to make because a lot of people don't understand that there really is a difference between a disorder and a disease. But I'll talk to you a little bit more about that in a second. Essentially, what we're talking about is a broad spectrum that basically consists of 2 buckets. And in one bucket, we have deficits in social communication, relationships with others. And in the other bucket, we have patterns of behavior or patterns of interests or activities that tend to be somewhat repetitive or restricted and over focus on specific things. Sometimes that focus will change from moment to moment. As I said, it is not a disease and it is a disorder. Because when we talk about diseases, we typically talk about something we understand at a much deeper level than autism. So for example, if we say we have a headache, then what we're saying is that we have something wrong, we have a disorder, but we don't know necessarily what causes the headache. If we say we have chronic sinusitis caused by an allergic reaction to pollen, then we're saying that sinusitis is a disease because we know something deeper about what causes it. And I think that's important because there really is a tendency for people to think when you give something a label like autism, and it is located in, for example, a diagnostic manual, and we think of diagnosis, we think of disease, and it's very firmly embedded in a disease model that we're doing something that is making this sort of more tangible and more real than it actually is. So again, that concept of the difference between something that we understand on a deeper level and how it comes about, versus a symptom or a set of symptoms is going to be a theme throughout the rest of the time that we're together, and is an important theme in working in general in the field. I don't know really who my audience is, so I'm not sure how much you already know about autism. I fear that perhaps I'm going to be too simplistic for those of you who know a lot about autism already. And on the other hand, sometimes I think I can get a little bit overly complicated. So it's a little hard to know exactly what to talk about. The idea is to be somewhat brief and give you an overview of the most important parts of the topic. And then we'll have, as Bianca said, sort of a question and answer period afterwards. And we can get into more detail. Very, very briefly, as most of you probably already know, the word autism itself comes from the Greek word autos, which means self. And it was originally described as a symptom of schizophrenia back in the early 20th century, back around the time Freud was writing, and back in the early days of psychology. And it was referring to an extreme withdrawal of oneself from life in general. That's important to understand because it contributes again to a lot of misunderstanding about what this thing is. A lot of people would question even the use of the term autism or the word autism to describe this. But this is often how it was seen. And really, it was in fact considered to be a symptom of schizophrenia at one point in our history. In the early 1940s, Leo Kanner wrote an article called Autistic Disturbance of Affective Contact. This was the first use of autism as something really different from schizophrenia. And Kanner described the inability to make emotional contact with others as this thing that differentiates autism from other things. There's a big controversy, and I love this kind of historical stuff. It may be entirely irrelevant to some of you, but it's, to me, quite fascinating. At the same time as Kanner was working, Asperger was working in Europe, and he described children that he called, that he referred to in very, very similar ways, although he was describing sort of kind of a different end of the spectrum, as we would call it today. He called a certain group of kids that he worked with little professors, and he actually wrote in German. His writing was not translated to English until many years later, and that's when his ideas became well known. So much so that we described these high functioning kids who had sort of extra abilities in certain areas and seemed really smart, but also kind of socially awkward. We decided to call those kids who had an Asperger's type of autism. I was trained sort of about the same time as fire was invented. So I was actually trained on DSM-2, the Diagnostic and Statistical Manual that the American Psychiatric Association uses. On DSM-2, which was published well before 1980. It's actually a beautiful document. I actually miss it very much. there was no diagnosis of autism per se. It was, in fact, considered to be a trait or a single trait within schizophrenia. 1980, there was a massive revision of the Diagnostic and Statistical Manual. It went from something like 80 pages to several hundred pages. It became a behavioral document as opposed to a theoretical document. And autism was considered a unique diagnosis, although in DSM-3 it was considered a subset of something called a pervasive developmental disorder, which is probably more information than we need. So that's kind of an overview, a little bit of the history. And so sometimes you'll hear people describe children as having autism of Kanner's type, and sometimes you'll hear people talk about autism of Asperger's type. We know the numbers, most of us, because it's in the news all the time. Back in 2014, when this particular slide was created, we were already up to 1 in 68 children. We had a 4-to-1 male to female ratio. Now, of course, the numbers keep changing, and the prevalence keeps increasing. And, you know, it's always a very popular topic of conversation. And those are the questions I get. Well, there's about 2 questions I get so often that I'm a little tired of them, and I hope that doesn't sound not so nice, but I do struggle with that. But everyone asks, you know, out of curiosity, why the increase? And it's very controversial, as is the other question, which is usually about vaccines. And I think that I share this view with those people of my generation who have experience working with children from a lot of different settings. And, you know, one of the things that those of us who are old enough to remember the children we worked with many years ago, you know, we have this common experience of saying, well, you know, if we look at so-and-so who we worked with 25 years ago, well, we would call that person one thing. We might label that person as having, well, actually, sometimes we would say pervasive developmental disorder, or we would say childhood schizophrenia back in the old days when we had that. Typically, we might say someone with a severe attention deficit without hyperactivity, or what we nowadays would call executive functioning disorders. You know, we gave those kids a whole lot of different labels, sometimes even intellectual disabilities. So those kids today would all probably receive an autism diagnosis. So is it really truly an increase, or are we simply labeling kids differently? I think most people these days say it's a bit of both. I'm not really convinced that it's a bit of both, but it doesn't really matter. We have kids who have who struggle, who need help. So that's the bottom line. There's certainly a broadening. There's no question about the fact that there's a broadening of the definition of what we consider to fall into the category of autism, even simply from having gone from a subcategory of pervasive developmental disorder to now where autism is the main label under which pervasive developmental disorder will fall. Some of the things we know, in fact, that differentiate people who are given the label of autism spectrum versus the label of schizophrenia, for example, we certainly see very huge differences. These are really two very, very, very different things. But one of the things that I find interesting is this idea of, what does correlate with the diagnosis. And one of the things that we do know is that it's considerably more likely that you will have a child who ends up having that diagnosis. If, for example, and this is a complicated slide, but the two, they're labeled, each box is labeled A, B, C, D, E, and F, which makes it easier to talk about. If we look at the relative risk of having a child with autism, notice, by the way, that the relative risk numbers are small. So it's not like we're saying there's this huge risk. That is to say, if you look at the y-axis, the vertical axis, it's only 1.4. So it's not a high risk. But nevertheless, you'll see that box A represents the age of the mother. So as the mother gets older, the last point is age 30 to 46. As the mother gets older, when she has the child, the risk of autism is considerably higher. If you look at D, the box below, you'll see that that there's essentially, the younger the mother is, the more likely that the person will end up with schizophrenia. So that's a very, very big difference. We have a similar pattern with the age of the father, which is even more highly correlated. As the father gets over 45, between 45 and 60, you'll see a considerably higher risk of autism. Paternal age makes no difference with schizophrenia. And then the last C and F boxes are the differences between the mother and the father's age. And essentially, that this is a little bit more complex, that if you have an older father and a younger mother, you'll see the sort of middle section is the same age, and then as you extend out, it's a bigger age difference. That the age difference matters, but not nearly as much as the age of one or two of the parents, if that hopefully makes some sense. I really don't like talking about vaccines because I sometimes and have almost been assaulted by parents, but we have the safety of you all being invisible to me, and I don't know that you even know where I am, so you can't hit me if you want to. But essentially, what we have here is an interesting, I think, demonstration of the prevalence of autism. With all kinds of autism is the blue line, relative to the to being vaccinated, which is the yellow line. That it's almost an inverse relationship, meaning that the fewer the year that the least amount of vaccines were given, you had I should say it the other way. It's easier to say it the other way. The years that you had the most vaccines given, you had the least amount of autism, and the reverse is true as well. Basically, you all probably are very familiar with the history there. The article that Wakefield wrote back in 2010. I'm sorry, I don't remember the original year, but the retraction was in 2010 when Lancet. It's fascinating, actually. The story behind the review of Wakefield and his research by the British Medical Society was the most expensive and longest investigation they had ever conducted in their history. Basically, the British medical journal in 2011 stated that he was, and this is their words, was that he was an elaborate fraud. So again, the more time we spend on that, the more upset we all get. So let's just keep moving on. DSM-5 is what we typically use here in the United States. And autism spectrum disorder is considered to be one of 5 neurodevelopmental disorders, the others being intellectual disability, a global developmental delay, which, and then ADHD, and a social communication disorder. Social communication disorder is somewhat of a replacement for Asperger's, but that gets complicated, so we won't get into that so much. What we know is that there's a big overlap, going back to the previous slide, among these things. We'll talk a little bit about comorbidities, and it's the lines between all of these 5 things are very blurry. I can't. So that's an important consideration. It's not like you say, well, I have a child who has this, but then therefore it doesn't have this other thing. And again, we'll talk more about that later, I think. So there's a huge overlap among those 5 things. We know that we're basing our diagnosis on behavior, and not on a blood test, not on a PET scan or a CAT scan or MRI. We're looking at behavior, and that's how we're making our diagnosis. And when we do that, we're not looking at where that behavior comes from per se, not until we're looking at how to treat it, but in terms of making the diagnosis itself, we're looking at simply what's in front of us. And the last theme is heterogeneity. You probably all have heard Stephen Shore, the professor at the University of Pennsylvania, who proclaimed himself as having autism, which he does. I met Stephen; he's a delightful person. But his famous quote is that if you've met one person with autism, you've met one person with autism, and that's so that's another way of saying that the people we see who end up having this label are much more different from each other than they are the same. And so we see vast differences in the behavior of people who present themselves as legitimately having that diagnostic label. So another thing that DSM-5 did differently from DSM-4 is they took these 2 main baskets, the social communication impairment on the left of your screen and the repetitive behaviors on the right. And you notice in typical wonderful Venn diagram fashion, the overlap between the 2. And then they added the dimensions of how well developed is a person's language, almost like a different axis or a different level of understanding somebody, and how much support does this person need, and those 2 things do come into play in making the diagnosis and in the prognosis, which we'll talk about some more later too. I think we're now 2.5 years or so out from in DSM-5, maybe more. So the changes from DSM-4 may not be as relevant as it was if you were giving this presentation a couple of years ago, when everybody was concerned and excited and wondering how the American Psychiatric Association was going to change things, which, by the way, I think is important to understand. And a lot of people, again, want to make more of diagnoses than they should. What really a diagnosis is essentially a committee of researchers, academicians, and a sprinkling of clinicians getting together, looking at the research, discussing things, and then making a committee decision on how they're going to write it up and structure it. And that's all that it is. Hopefully, with good intentions, and the intentions being that the better we can understand what we have in front of us and the better we can label it, then the better we can find an etiology or the hundreds of etiologies that there probably are, and hopefully the better we can treat what we have in the long run. One of the key differences between DSM-4 and DSM-5 was that there are certain rules that the American Psychiatric Association likes to give us, or as guidelines. And one of the rules they gave us in DSM-4 was that you couldn't have ADD or ADHD and have autism at the same time. That one thing excluded the other. You either had to have one or the other. You couldn't have both. Well, turns out that this is a good example of the committee who created DSM-4 just simply not really understanding things at the level that they did when DSM-5 was put together. And now the new rule is that you certainly can have both an attention deficit disorder and autism. And in fact, the more you look at those two disorders, the more you find commonalities, especially primarily in the areas of executive functioning, things like planning ability, difficulty with transitions, the ability to schedule time, and that sort of thing. I did have a couple of short videos to show you, but when Bianca and I tried to practice this, we realized that they didn't function with this webinar system. So I was going to show you the difference in something called joint attention between someone who we might call, for lack of a better term, and this term changes all the time, neurotypical, versus somebody who ultimately received a diagnosis of autism. The joint attention concept is essentially this idea that there are three points of contact, if you will. There's one person, the person we're interested in, and something out there in the world, and that when one person says, "Look at that," or pays attention to a particular thing or experience or object in the environment, then the child also pays attention to that thing. They share the interest in that thing. And kids typically can do this at a rather young age, whereas children who end up getting a diagnosis of autism have considerable difficulty with that joint attention. And obviously it goes, if you think about it for a second, it becomes obvious that once you have difficulty with joint attention, it makes having a relationship with another person much, much more difficult. The other thing we notice, and I have videos for this as well, is the difference in play skills. And here you find a lot of the restricted interests and the difficulty shifting attention really come out. So typical 3.5-year-old play is interactive to a large extent. So even if the child is very intently focused on what they're doing and pretending or whatever, And the adult says, oh, then maybe we can do this, or maybe the child can, or you know, maybe the bear can be, or like, for example, the adult takes the bear and pretends to talk with the bear and laughs, and the kid laughs. Those are things that you do not see typically with kids who end up with that diagnosis. Autism is typically diagnosed in children between ages 3 and 7. That's when we see it often. But we also know that parents in general are concerned about their children well before that, especially if a parent has had another child who's developed really differently. So parents often have a sense that something's not quite right. Early diagnosis, of course, is essential because the concept of neuroplasticity tells us that we are, and the research tells us that we are much more likely to be able to impact a child's learning when they're considerably younger. I think it was it Karl Marx who said, give me a child, and by the time they're 3, I'll make them into a communist, or something like that. We know that that brains are much more malleable when they're younger. So the older a child is, the more difficult it is to make the kind of progress we want to see. But the reason we don't get those diagnoses early on, there are many reasons. One reason is that if you have a child who's got many different care providers, there is kind of a diffusion of noticing, if you will, or even responsibility to notice. A little bit like the old bystander effect. If you know that if you're in a group of people and you see something, you're much less likely to do something when there's other people around. If you're living in a rural area, you have less contact with other people. If you have less financial resources, then often you don't have the resources to have the diagnosis be made. I would add to this list that if you have there are still some pediatricians out there in the world who are reluctant to make the diagnosis for obvious reasons. It's a hard thing for parents to hear. So they don't. They say your kids will grow out of it. Also, and this last point is very obvious, that if you have a child with very severe language deficits or very obvious symptoms like, flapping their hands or walking on their toes, then of course those children do tend to get diagnosed quicker. So what we know is that if you have reduced attention, reduced social communication, repetitive behavior, and especially if you have delayed motor development along with those things, between the ages of 1 and 3, then it's probably a really good idea to get an assessment, because those are real clues that there may be something going on. As I said earlier, many parents may suspect something's wrong with their child, something's developing differently prior to 1 year old, but unless it's extremely severe, they're going to be cautious about that. And we know from research that we haven't been able to reliably diagnose under 1 year of age. A lot of clinicians, and sometimes me in my hubris, will believe that we can. But I think that unless we're dealing with a very, very extreme, low functioning situation, the truth is we're not very good at it under the age of 1. I said earlier that we don't know where autism comes from, but here's what we do know. We do know that it is extremely heritable. By heritable, it means you can get it through the genetics of one or both of your parents. How we know that is because if you are an identical twin, then the probability of both twins having autism is extremely high, 60 to 70%. So, and if you are dizygotic, if you're fraternal twins, you're not identical, then the concordance goes way down to 10 to 15%. So that fact alone tells us that there is something genetic, because if it was simply the uterine environment, is obviously the same whether you're monozygotic or dizygotic. So we know that there's definitely a heritability factor. And there's something that actually I don't think you can see. It got cut off in this particular slide. Is that if you have more than one child with autism, then there is a much higher rate there's a much higher likelihood that your next child will also be likely to have autism. That's still 33%, which means there's a 67% chance that your next child will not have autism, but still that's a considerably higher rate than if you don't. But one of the things that's changed in the last 20 years is that in the old days we used to think that genetics was all about what you've inherited from your parents. Turns out it's a lot more than that. That there's also a field called epigenetics, and epigenetics has to do with what we call de novo mutations, which are mutations in DNA that occur actually from the environment, and or for reasons that we don't understand, but that they're not coming from prior generations. They appear for the first time. Noticing that I probably was a little bit overly optimistic about how much we can cover in the time we have. So please forgive me if I tend to kind of move quickly to the treatment section. We're getting close. We do know, and I think this is important, that we can identify genetic disorders in approximately a third of children with autism. And so, for example, we have disorders of one particular gene that we've been able to identify for tuberous sclerosis, Fragile X, Rett syndrome. And then we have 20% of those where we cannot identify a single gene. But we know that there is something genetically different about that child in some chromosome. I used to try to collect articles and on what these genetic mutations looked like, and it started to sprinkle in, and then the numbers got so big that I couldn't collect those articles anymore, and I gave up. So there are hundreds of mutations that we're now noticing that do seem to correspond with autism. So where we thought that maybe autism might have been the result of 10 or 15 or 20 disorders, now the suspicion is that we're looking at potentially hundreds of disorders, or potential disease, if you will. I'm going to quickly talk about comorbidities because I'm worried about time. Comorbidities are things that exist along with autism in general. And I'll just say quickly why that's important. It's important because it changes the way we approach the child and the treatment we give. So for example, seizures is very common. GI, gastrointestinal disorders, diarrhea, constipation, very common. Up to 80% of kids with autism have sleep disturbances, eating and feeding problems, anxiety, depression. I'm seeing personally a whole lot more kids who, as they get older, seem to be leaning towards bipolar disorder. We mentioned ADHD. There have been studies which have talked about 30% of kids with autism having ADHD, all the way up to 100%. And when you get to 100%, you get to a very interesting discussion, which we won't have today. Let's kind of move to the treatment area so we have time for questions a little bit. Here's what we know in a thumbnail about what works, what's helpful. And this was published back in 2000, almost 20 years ago. There's been a lot of research since this book was published. None of the research that's been published since then contradicts any of this. So the generalizations that we had 20 years ago about what works still works and is still correct. There is something called a dose-response relationship. And by that I mean that in general, the more intervention you have, the better. Initially, Lovas's early studies suggested 40 hours a week of intervention. We know now that we really ought to have at least 25 hours a week. That's a complicated subject unto itself. We know that the closer we get to a one-on-one ratio when we work with kids, the more effective our interventions are. We know that we want our interventionists to be well-trained, and we want to know, especially because all our children are different and they all learn differently, that we don't give every child a canned, off-the-shelf intervention, that we design each intervention specifically for the needs of that child. I will tell you, this is one of the more interesting slides, and it's based on a study that just came out very, very recently of adults who completely lost all of their symptoms of autism. And what we know is that a very, very large percentage, it's actually about 50, I can't remember exactly off the top of my head, it's a little difficult to make out, roughly 54, 56%, I think, of adults who were completely symptom-free as adults who received ABA therapy when they were children between the ages of 2 and 3, we know that they became symptom-free. So almost 60% of those children who received ABA between ages 2 and 3 were symptom-free as adults. You could not tell the difference. Of those people studied who received ABA between ages between 2 and 3, 7% made virtually no progress at all and maintained their symptoms. So I could give you that study later on, or we can have that written to me. I know we want to stop it in about a minute for questions. So let me just say that
a little further, we can have about 10
yes,
minutes for Q&A if you would like.
Yes.
So no problem.
Oh, that's great. I appreciate that. Thank you. So, and we really are pretty close to the end. So many of you, there are only a few interventions that have solid research behind them. And the closest to ABA or stricter ABA that does have some good support is what's called the Early Start Denver model, which occurs in the natural environment. And it's kind of a broad-based intervention. Unfortunately, the studies of the Early Start model are not great, and there's not a lot of them, but it is considered evidence-based. It's applied behavior analysis is a group of thousands of techniques, and I literally say thousands because there are so many refinements of each kind of intervention within this collection of tools that are used that applied behavior analysts bring to their work. There are journals full of articles. Most of them are single case studies or 2 or 3 kids that, where a specific intervention is tested. But when you put all those together, they come up to quite an extraordinary amount. But they all share certain things in common. I just want to say one thing, because this also comes from a study done very recently. And rather than give you old information, I want to give you some new interesting information. Functional MRIs, it's a very interesting technique. I'm not a big fan, but it's sort of state of the art. What's some very recent research has looked at is where activity occurs within the brains of certain of all of us who are studied that way. And what we found is that when we do intervention, ABA, with kids who improve significantly, and we compare them to the parts of the brain that are lighting up, if you will, in neurotypical kids, surprise, surprise, they're not the same parts of the brain. So what's very interesting about these studies is that, or this particular study, is that we find that when we intervene and kids do better, what we really truly are doing is we're training, if you will, a different part of the brain to compensate for the skills in the parts of the brain that don't seem to want to do what they do with typical kids. We could talk forever about what we call alternative treatments. Parents, understandably, all of us will try anything and everything we can. And sometimes they work. And when they work, we don't know why necessarily. So we try to do research and understand why they work. When we do research, we typically find that that what we thought was working isn't necessarily what's working, or they have placebo effects, which is great. It's real, it works, but it's not working because of the thing we think that it's working for. So in other words, we may give a particular kind of treatment, and that particular kind of treatment also increases the amount of attention on that child and the amount of intervention that child receives. And it may be more that than the treatment itself. Really quickly, what we know is that people who have higher IQs to begin with, better language skills, this is kind of obvious, and fewer repetitive behaviors, children who have the ability to engage in imaginary play tend to do better in treatment. So to finish up, that basically autism is not a disease. It's a behavioral diagnosis based on symptoms, and that it is a broad spectrum. It is not based on a known source, a known etiology, because we often don't know. We know that kids on the spectrum are more different than they are the same. And that we didn't talk about medication, which we didn't have time to do, but basically medication tends to be effective only for specific symptoms that we're trying to medicate, not for any of the core deficits of autism. So why don't I stop there, and we can go to questions.
So if anybody has any questions, please feel free to add in the chat box to the right-hand side. I know that Jean Stevenson went ahead and stated that they would just like information on ABA use with the older child. So for example, a preteen.
Okay. You know, that's actually a great question. And I love that question. So ABA is an approach that has nothing, how do I say this? It's essentially a collection of interventions that share certain things in common. So they share in common this idea that we're going to look at the specific individual needs of the child. And that's going to be, no matter what their diagnosis is, no matter how old they are, we're looking at their needs. And we're going to design an intervention for that specific child. And I would say, typically we take data, that's important. And also we're looking at the function of the problem that we're trying to address. Is it because the child is wanting to get out of doing something, because they're wanting something like attention? You know, so is it because they're getting a physical thrill out of it? We want to understand the reasons these things are occurring. And once we understand the reasons, we address interventions specifically for that. So the bottom line is that it doesn't matter how old you are. I used ABA approaches when my 80-plus-year-old mother was refusing to eat, and was everybody around her was telling her that she needed to eat to survive. And I simply said to everybody around my mom, well, what does she do if she's not eating? And they said, well, she watches Judge Judy all day. That's all she wants to do. So I said, well, just turn it off and tell her she needs to eat in order to watch Judge Judy. and she did. Well, that's ABA. It's also common sense, but it was with an 80-plus-year-old woman. So age doesn't matter.
Thank you. Another question is, what is the difference between autism and Asperger's?
Great question. So in right now, there's no such thing as Asperger's if we want to be technical about it, but that's kind of silly. That's just because of the committee decided that they were going to take that away. So we don't have that anymore. But really what we're talking about is something that in the old days, which was like yesterday, we used to call kids with Asperger's as having high functioning autism. And there was simply one major distinction, and that distinction was their ability to use language. So if someone had no difficulties with language in expressing themselves, but still had all the other kinds of autism, then we would give them the label of Asperger's. And that was really the only difference.
Thank you. So I have one final question from Evelyn Reyes. She wants to know, what is your advice for handling a situation in which you are almost positive a student is autistic, but have a parent who is in denial and refuses to go further with assessment? The child is 3 years old.
Well, that's very common, and that's really difficult. You know, what I would do, and like I said, it's not an easy situation. And I don't necessarily do what you would do or what someone else would do, because I have the ability to kind of draw on my balding head and my gray beard. And I suspect, Evelyn, you don't have a gray beard. I don't know because I can't see you, but and I can talk a little bit about my experiences with a parent. You know, one of the things you could do is simply express your concern for the child, period, without using the label. And you can, I'm assuming you're a teacher. I don't know if that's true. But from the question, it sounds like that. And essentially, you can use your experience as a teacher to say, you know, over the years, I've seen a lot of kids, and I've known a lot of kids, and I'm really concerned about your child, period. And you could even go back and say, I just don't know, but I'm concerned, and I think we should look into this deeper. And simply not push the autism label. Well, I do something a little bit different, which is that I talk about the meaning and the meaninglessness of the label itself, because I truly deeply believe that it's not a terribly meaningful thing unto itself, and that the purpose of the label is essentially to get help, and that help is going to look different for each child. And so, I say, you know, if the insurance company or the school district or whoever is paying the bill is going to pay the bill if we give the child the name of Fred or Denise or Alice, then maybe we should change the name to Fred or Denise or Alice, because it'll get where we need to go. The main function of the diagnosis is to get the services. And so knowing that, I may say to a parent, look, it's not meaningful to say autism, because, you know, I could get that label if I wanted to, not too easily, or, you know, because it's such a broad definition. But what is meaningful is that we get your child the help that we think your child needs. And unfortunately, this may be the only ticket we have to get that help. So sometimes that's the way to go. An interesting phenomenon that I found is something very different from how it used to be, which is that sometimes when I give the diagnosis now, I'm surprised at the relief that certain parents have, saying, oh, thank you for doing that. I always knew there was something wrong. Now I know what it is. Well, you know, I'm not even sure I know what it is, but if that helps you to feel better, then good. Let's use that. So I've been finding a lot more parents a lot more willing lately to be labeled. Anyway, have their child labeled, I should say.
Thank you. So I did have one final question, but I hope that it overlapped with Brianna's question. I believe your answer overlapped a little bit. We do have a minute left, so I may email you this question afterwards, and I can send her that response. So I just want to go ahead and thank Dr. Heilveil for being our very first webinar speaker for our Autism webinar series. We do have 3 more webinars for the month of June. They're every Tuesday at 6 p.m. So please go ahead and register for those. I want to thank everybody for being able to watch this webinar with us, and have a great night. Thank you so much.
Thank you very much. Bye.